Hello, everybody, and welcome to the GHP Brown Bag Seminar. This is Jacqueline Barber, and I'm sorry I'm having difficulties connecting my video link for some reason, so please forgive me. I'm there very much in spirit, but unfortunately you can't see me. So I'm delighted to introduce my friend and colleague, Dr. Stefano Angeleri, who is a postdoctoral fellow at Queen's University, Belfast, and also in the Universidad del Rosario in Bogota, Colombia. He was a visitor at the FXB Center last semester, and we worked together on a range of different projects related to human rights, health, and migration. And he and I now are collaborating, in fact, on a special issue of our Health and Human Rights journal on that topic. He has a lot of experience of working on the interface between law, migration, and health, and is particularly expert in this work in Latin America, where he's done multiple projects, including projects with the Jesuit Refugee Service, with PAHO, and with Doctors of the World. So really delighted to have him. He recently published, I think, what was his PhD thesis. It was published by Cambridge University Press, and it's called Irregular Migrants and the Right to Health. It's a terrific monograph on the topic, which I very much admire. So today, Stefano is going to talk about his research in Colombia, looking at issues related to migration and human rights and health. So, Stefano, thank you so much for joining us, and I'm happy to hand the floor to you.
Thank you very much, Jackie, for your kind words of introduction, and thank you to the Department of Global Health and Population at Harvard School of Public Health for hosting this seminar. It's such a pleasure to present my research to you, and I look forward to your feedback, critical feedbacks on the work in progress, on this work in progress paper I'm writing on primary healthcare as a standard, as a framework to identify the core content of the right to health for irregular migrant populations. So without any further ado, perhaps I know, Jessica, you have half an hour, I don't remember well, for the presentation.
Yeah, about that. That sounds good.
Yes. Okay, great. Thank you very much. So I have a presentation, and yes, so I would start by sharing my screen with you. Let me just see. Share. I think you can. Jackie, can you confirm it? You can see my screen?
I unfortunately,
yes.
I'm
yes.
having some challenges here, but actually maybe,
yes.
But can everybody else see it? Okay,
yes,
good.
We can see
great.
it.
Thank you very much. Thank you. Okay.
You can put it on full screen if possible, but if not, it's fine.
Is this not a full screen?
Let's
Wait
see.
a second.
Yeah, looks good. Sorry.
Okay, thank you very much. So yes, the paper I'm working on is titled "A Primary Healthcare-Based Approach to Migrant Health Rights." This is a qualitative study from Colombia. It was during the last 2.5 years. I've worked between Colombia and the Republic of Ireland and the UK on this Marie Curie project. It's called the funding is called Mary Skłodowska-Curie. It's a very interesting funding if you have some postdoctoral fellow that would like to pursue research in Europe and outside of Europe, but with a European base. And it's part of the Horizon Now Europe research funding. So I would like to just to to mention this beforehand because this is the funding of the project. And the reason why I started to work in Colombia and on this particular project is because in my previous work, mainly as social legal scholar, I could identify as the problem for me from a human rights perspective is that the provision of emergency care is a widespread approach to interpret the scope of the right to health for non-nationals. Mostly, within the legal framework of many nation states. Of course, this approach is then complemented by many non-state actors. But from a human rights perspective, duty bearers of the states. And so this appears particularly problematic to me from both a human rights and public health perspective. It's a very constrained approach to the provision of emergency medical care. So in looking for tools interdisciplinary that could help me anchor the right to health of non-nationals to a more generous standard setting. So I found primary health care. Actually, it's a few years that I'm working on this. And my hypothesis, and my research question for this study, for this paper, would be: can we consider primary healthcare, as a framework, as a strategy? Can this serve as a blueprint for priority setting and for establishing and implementing a core content for the right to health of non-national when states are unwilling to fully meet their obligation regarding migrant health rights? Because this is the starting point. So, it's pretty clear to me that from apart from rhetorical declaration, nation states are not willing to fully realize and fund healthcare for polity outsiders like undocumented migrants. So to answer this question, I have conducted a case study in Colombia assessing and observing the multi-actor response to the health needs of Venezuelan migrants. In Colombia, there are at the moment almost 3 million Venezuelans that have settled, are residing in Colombia. Over the last, I've been residing and settling down 3 million people over the last 8 years, but many more are transiting. And this works for me, in my idea, from a methodological point of view, as an intrinsic case study, so to understand the power and the forces in place, but also as an instrumental case. So there is a certain level of this study that could be generalized. I'd explore the opinion, the experiences, and the forces that can either enable or constrain a meaningful right to health in the migration context. The case of Colombia is particularly interesting to me also because the legal framework of Colombia is very generous. Human rights law as an end-all. There is this very challenging migration phenomenon going on. A very strong constitutional court with the power to adjudicate and to order different authorities to take general measures. So it's very interesting from that point of view. And also it's a very challenging context also because of armed conflict, internal displacement. So the idea was like, let's listen and let's learn from the field, from a very challenging field, to see what people think about the content and the meaning of the right to health from different fields and different sectors of the response to ground a minimum core rights based on these interactions with different actors. So the data collection took place in 2022 and 2023. Apart from a desk-based research on primary sources of regulation and secondary sources, the empirical work consisted with a few periods of observation in the fields with the Jesuit Refugee Service and with the IOM, the International Organization for Migration. So I went to 3 different territories of Colombia, around the city of Bogota, and in neighboring areas in the neighboring region of Cundinamarca, and at the border with Venezuela in the department of North of Santander, to understand the dynamics of the response of the actors that responded to the health needs of migrants, and also for selecting people for interviews. Then I conducted 20 semi-structured interviews with 30 persons with a medical background, development, NGOs, actors, and then 4 focus groups with 36 community health workers in the 3 territories. And finally, the information was complemented by 11 replies to requests of information to health authorities and hospitals. So a few premises. I mean, I won't use much time to cover this. So it's behind the, in front of the eyes of everyone that over the last 20 years, from different fields, different disciplines, there is an increasing attention to health and migration, and also to the mutual relationship between health and migration. Migration cuts across all the social determinants of health, and this is a very interesting framework, in my opinion, that human rights practice and scholarship should consider progressively more and more in the coming years, instead of focusing perhaps on the right to medical care. And this is a public health school, so I won't waste any more time explaining to you, a lawyer explaining to public health specialists what a social determinants of health framework is, but it's important also for human rights agents and practitioners, because the intersectoral actions that can address the determinants of health also in the migration context are reflected to a certain extent in the normative content of many different human rights that relates to health and well-being. So I already mentioned this, that bold declarations on the universality are routinely contradicted by laws, policies at both domestic and also the international level. No later than last year, at this period of the year, there was it was held in Rabat, the 3rd global consultation on migration, on the health of refugees and migrants. The Rabat Declaration that followed bold declaration on the universal rights to health, but actually there is a mismatch between this rhetorical declaration and political declaration, and then the actual service provisions and the service provision, and also the incorporation of human rights and the human rights to health for all people on the move within the domestic standards. Another starting point is that human rights means very different things and has very different implications for different sectors. And of course, all these sectors have different trade-offs. And for this, it's very complicated to work in this field. And many of you that are engaged in interdisciplinary research are also aware of this. And my take on international human rights law is an interdisciplinary and experimentalist approach to human rights. And so I value a lot the interaction between different actors and sectors to give a meaning to these international standards, nourished by the contact with communities, citing Paul Farmer. So searching for this other interdisciplinary tool outside of human rights to reduce the health inequalities that could benefit irregular migrants, primary healthcare appears particularly relevant because it enables observers to focus on the constraints of the national policies towards undocumented people that are clearly unequitable and not rights-based. And also envisions, mostly if we look at the Declaration of Alma-Ata and the standards of the declaration, a core content for migrant health rights. There is a lot of emphasis on universal health coverage, but this could work as an intermediate but meaningful step towards the achievement of that goal. from this table, you can see the different synergies that we have between a right to health framework and the primary healthcare model championed by Alma-Ata, especially the core principles of human rights, the cross-cutting principle of human rights, based approach like equality and non-discrimination, participation, accountability. And so they are reflected also in the Declaration of Alma-Ata when health is established and indicated as a fundamental human rights with state obligations. State obligations also that relate to education, participation, and empowerment, and this and human rights for, I mean, in the different meanings that this word have, can allow that empowerment of community and participation of community in defining the best standards for themselves. The hypothesis that for me and you, I would like to hear your opinion on this, is that while a primary health care approach might guide health policies, priority setting, and a threshold identification to realize the right to health equitably, reaffirming it as a human rights standard should enable greater legal and social accountability vis-a-vis the duty bearers, so state authorities at different level of governance. So few words on the national context in Colombia. So it's a social health insurance system. So the state withdrew from service provision in the 90s. And there is, for people that cannot affiliate with the system or are not affiliated with the system, with the social security system and the health, there is a residual right to emergency and urgent care. The administrative law and also the constitutional jurisprudence has differentiated emergency life-saving treatment, stabilization of vital signs from broader urgent health care. Unfortunately, in practice, in different health centers around the countries, this, I mean, urgent care tend to become emergency care because often the fears of not recouping the cost of the service provided. So looking at this initial exercise of identifying themes within the data collected, first exercise was to identify what meant right to health for the stakeholders I interviewed and people I met in focus groups. And it was the most recurrent word was the well-being. Was the well-being of people, not only a physical well-being, but also an emotional well-being. So I would like to read the quote, a very powerful feedback from the field that relates to this emotional well-being of people that is important to understand and to target and address also through legal means. We arrived in Colombia carrying a heavy emotional burden. Can you imagine what it's like to see your children and those of your neighbors losing weight due to lack of food, walking for days in the heat and cold, only to be treated as third-class citizens, human beings, because you are not from here and because you are poor? So apart from that, people also tended to stress the interdependence of different rights and services, which pretty much speak to this interdependence of human rights. And then importantly, several people also highlighted the importance of the right to health for the right to life. And so for some of them, actually, it was the life was mentioned as an interest behind the right to health. But for others, for many others, it was mentioned that actually this is not enough. And so the right to health was protecting the well-being of people, the dignity of people, and providing only life-saving treatment was insensitive to the dignity of people and while they were feeling unwell until they are considered suitable for emergency care. Unfortunately, and this is mentioned as a justification, but also as Unfortunately, the right to health is constrained by a number of conditions. Let's put it like that. Considering that my fieldwork was during a massive regularization schemes in Colombia, and so many people I met actually were justifying the restriction of the services because people were not registering, regularizing their status, and as such, they had the document for the social security affiliation. For many others, actually, this had a victim blaming effect because actually for many people it was impossible to regularize their status because they had entered the country after the cutoff date. Or for others, also this created a liminal legality because it is important to consider that regularization schemes like that created a status of temporary protection, and this status could be easily taken away by executive powers, migration authorities, even because the person is considered undesirable. Law is a determinant of migrant health, and this was very recurring theme during my interviews. It can constrain service provision, as we have just seen, but human rights laws could also provide the grounding for an expansive jurisprudence. And actually, human rights was very important for the Constitutional Court to expand the definition of urgent care. Unfortunately, this jurisprudence was important for vindicating these rights in courts and couldn't affect so much public policy making and programming. So in many cases, even services that are considered for the court part of human rights are actually provided by humanitarian actors, or it's necessary to file a legal claim with a judge to get access to that particular service. And it's important also that the law, international law, demanded the creation of partnership, and this partnership between state and non-state actors also created in individuals, in migrants, the feeling, the perception of enjoying de facto rights offered by service providers that are not state. Unfortunately, this structural compensation, as a colleague from Austria, as Dr. Trummer defined, the structural compensation of non-state actors created certain side effects. And from a human rights perspective, because it reduces the availability of service. So if humanitarian actors or NGOs do not fund or close the program or close it or leave the territory, the health needs are left unattended. And also reduce accountability because the user cannot demand the quality and the provision of actual services. Most of humanitarian actor NGOs are concentrated around cities and in suburban areas. And many actors refer to me from UN agencies and NGOs that once they cover, for example, primary care provision, the state doesn't see it anymore and do not feel forced to then think about long-term solution and then extend services to migrants. If we want to use the framework of primary health care as a reference to extend state-sponsored care for migrants, also with a strong human rights accountability mechanism, I discussed with different stakeholders what the elements of this primary healthcare approach should be. So basically what the essential services that at the moment many humanitarian actors and NGOs are providing should the state take as services provided by the state and different territorial authorities themselves, and as such linked to different accountability mechanisms of legal and social nature. One element, which is also one of the core elements of the primary healthcare approach, together with public health interventions, is primary care. So at the moment it's provided by actors that are not state actors, but it was considered like a starting point to discuss the right to health of non-nationals. So strengthening the first level of care and make it truly accessible for the health service director of an NGO I met in the field would prevent reaching complication and unnecessary suffering. And unnecessary suffering was considered as a fundamental interest behind the right to health. But also another fundamental interest and principles that human rights protect is human dignity. And another person I met in the field told me, like, where is the dignity of people when they feel unwell and when they feel unwell, but they're not so unwell to get access to an ER. So this was very powerful to me and very, very interesting to learn from their experience and their frustration of being unable to build the capacity of duty bearers to respond effectively from the state perspective to the health needs of people. If we disaggregate the data on nationality, Venezuelan national wish for primary care visits and screening to be available as a human rights, which at the moment is not the case. And Colombian national were more concerned, knowing better how the deficiencies of their system worked, actually were more concerned about the actual availability of essential drugs, which is not guaranteed by the fact of having access to primary care clinics. And also there is a very different, there are a lot of differences between areas of the north of the country that I visited at the frontier with Venezuela and the central area of Bogota when it's up to access to primary care visits, because in some cases in the north, you could wait several weeks and months to get access to a primary care visit. Another important element to identifying the element of primary care that should become or should be restated as a core content of the right to health are community intervention and participation. So strengthening community intervention should include, according to many stakeholders I met, supporting community health workers. Supporting community health workers that facilitate, of course, the enjoyment of the right to health by marginalized communities, so bridging this gap between the health services and communities. Health services, state-funded or NGO clinics, but also they can perform different activities that speak very much to the shared element by human rights-based approach to health and primary healthcare model, which is the participation in health policy making. They have the potential to contribute to participation in policy making, to become community health committees, which is not the case at the moment. And this is an anecdote. We have been working with community health workers, with human rights education to help them demanding the participation, to encourage them to demand to participate in this health policy making at local level. In particular, I mean, the invitation was for migrant community health workers working in this network of leaders. Another area which is traditionally indicated in the Declaration of Alma-Ata as a priority area for primary health care is the care for women and children's health. It's interesting to see, as a lawyer, a lot of endless pieces of jurisprudence and of law and regulation talking about the priorities that women and children should enjoy as rights holder, as historically and vulnerabilized communities, and the importance of human rights principle like gender equality and the best interests of the child, to stress the human rights of women with regards to sexual and reproductive care and of children for comprehensive care. But actually in Colombia, like in many other parts of the world, actually these human rights arguments are contradicted by the practice that that actually irregular migrants only enjoy emergency care as far, also around the sexual and reproductive care, and when rights holders are children. And so outside of charitable service, only emergency care is the standard of care that is provided for them. And as far as sexual and reproductive care is concerned, we have many people reported the increase of syphilis in migrant communities, and the importance of addressing gestational and congenital syphilis for the health and well-being of the fetus and the newborn, and an health issue that could be detected by antenatal care that should be, according to the Constitutional Court, part of the right to health, but which is not in practice. Also because there is this mismatch between a service that is provided in ambulatorial care and the fact that the Constitutional Court says this is emergency and urgent care. So there is a problem of conversation, of intersectoral and interdisciplinary conversation between decision makers. And another element which is very important, but it's just one of the elements that I have the time here to report on, is malnutrition management. Malnutrition management can, for irregular migrant children, be only managed in emergency care. But then these children go back to their environment and without the support of different social services and different NGOs, actually they go back to a state of suffering and malnutrition and severe malnutrition that can be very dangerous for their health and well-being and eventually for their dignity. Of course, if we want to use primary healthcare as a standard to identify core rights for migrants, we cannot keep our conversation to traditional categories that are considered vulnerable, like children and women. But there are other areas that were brought to my attention as fundamental to be tackled, like communicable diseases, the early detection and management of common non-communicable diseases for all in primary care, but fundamentally other areas that speak to the social determinants of health. Migrant communities often live in very dire living conditions. There are several people relying on sex for survivals that live in overcrowded and dire conditions in the city center of Bogota, paying per their accommodation in very unsafe neighborhoods, but also those that are more settled live in neighborhoods where no access to water and sanitation is guaranteed. Also, but this is not just an issue for undocumented people, but particularly for them, the quiet totality of migrant workers, in particular if they are undocumented, they work in informal and underpaid employment, and when you get the minimum, let's say $2 per day, you cannot afford co-payments necessary for healthcare. You cannot leave your work because perhaps your manager, your employer do not allow you to do so, to attend visits. And so it's employment conditions were often referred to me as fundamental factors to consider, even if we are talking about primary healthcare, to identify this minimum core standard, this minimum threshold for the right to health, for the right to health and the core content, for a core content that cannot fall below that. I don't think we have time to discuss further other factors because I would love to hear your feedback on this, but I would like just to finish on the contextual and structural barriers that even if primary care, preventive care, sexual and reproductive care, and other elements of primary healthcare were to be extended to irregular migrants, there are also certain contextual and structural barriers to consider and that should be addressed because otherwise the extension would be useless. So, well, first of all, let's say a basic element that prevents extension of rights is the political will at national and regional level. But there are also structural problems with the health system, and perhaps I have the time just to focus on a few of them. When I mention privatization, I'm not only mentioning the clear privatization of the health system in Colombia, but also a mentality. So there is often this perception in the society, in Colombian society, after the serving being privatized over the last 30 years, of deservingness. So you work, you contribute to our system, you have the right, and you should enjoy a right to health. If you are a community outsider, you do not work in the formal sector, and you are a migrant. So there is this underlying deservingness, undeservingness issues over there in many conversations that I had. And then, of course, the system is a highly fragmented system. So in certain areas of the countries, for example, there aren't, also in terms of availability of services, if we talk about the right of children, of the right to health of children, the pediatric care, but there are perhaps only 7 pediatricians working in 15 clinics. Most of them are private. Even if we extend legally the right to health to children, actually many children wouldn't be able, even migrant children, to get access to pediatric care. And cross-cutting issues that are barriers to inclusions, even in the best case scenario of inclusion of primary healthcare and preventive care in the health policies. Out-of-pocket costs can have a disproportionate effect on people that, as we have seen, are in the majority in a socioeconomic disadvantaged position. Xenophobia that can prevent access to essential services. Aporophobia, so the discrimination against poor people, and many administrative burdens. So I would leave it here because I would like to hear your feedback on this idea of considering primary healthcare as a guide to identify a threshold for everyone, regardless of their migrant status. Apologies for rushing up a bit, and also apologies for speaking perhaps long and focusing on certain areas. But here in Ireland, it's almost 7 p.m. and my brain is gradually switching off. Thank you very much.
Thank you so much, Stefano. I think that was a fascinating. Am I still muted, or can you hear me? You can hear me okay? Yeah. I'm working with 2 different screens here. So I think that was fascinating. Maybe I'll start with the question and then open it to my colleagues. So it seems to me that the idea of using this combination of a human rights framework of the right to health on the one hand, and the primary health care kind of Almata Declaration on the other, and bring these 2 together is a really good idea in the migration context, where very often kind of basic entitlements are precarious. But what I wonder is, from what I understand from what you were saying, there are 2 issues that really affect the Venezuelan population in Colombia, and I'm sure it would be similar for other migrant populations. One is the whole question of registering their status, whether they entered regularly or irregularly, whether they even have the documents, the basic documents necessary to prove their identity, and so on. So that is a distinctly migrant problem. That's not a problem, I presume, that Colombians would have, to show, but I would like to hear that, do Colombians have to show an identity card or something? Certainly for migrants, particularly, irregular migrants, this is a problem. But the second set of issues that you talked about would certainly be common questions of access. You talked about getting permission from your employer to leave work, and being able to make a co-payment. Those would affect poor Colombians too. So I just wanted you to say a little bit about how you see the relative position on the one hand of migrants who don't have a legal status or haven't been able to prove their legal status on the one hand, how that impinges, but on the other hand, how much more general questions of poverty and, you know, oppressive working conditions and so on would deny people access to care that they should be entitled to. So that just want to hear a little bit about this, you know, in other words, you know, what is distinctive about being a migrant in this context as opposed to being a poor Colombian working maybe for an, you know, an oppressive employer?
Thank you very much, Jackie. Yes, yes, so registration is a big issue because a lot of the emphasis was placed on this regularization over the last few years, and also this has created the impression that who doesn't regularize, so they are not deserving to get access to certain services. But Colombian people, they have an ID, and with the ID they can register to social social insurance, and so they can pay with their contribution to work, employment contribution, or those that are disadvantaged, they can have access through these social security schemes that gives access to health care. So basically they are affiliated with the system. Migrant people, in many cases, they were prevented. I mean, they were not given. So if we need to register with an health insurance, I need an ID, and I have a Venezuelan ID, and that's not enough. So I need I need a certain document, because otherwise it's not enough for all these actors of the health system. And in many cases, they cannot have them. They cannot have this temporary protection ID, because at the moment there is no regularization system open. It was open during 2020, 2021, and 2022. People that enter irregularly after 2021 January, they couldn't actually enjoy, they couldn't regularize their status. There are other ways that are employed by different legal actors to help them enjoy healthcare. For example, registering them as asylum seekers, so they can temporarily access all the services. You raise a good point that many of these barriers that I mentioned also affect poor Colombians. Yes, mostly in terms of looking at these factors, these social determinants, these social factors. As far as healthcare is concerned, if you are in a disadvantaged position and you can register, you should get access to certain services. But it's also true that a poor Colombian that lives in a remote area, they are in a similar condition with an irregular migrants, because the system is not very responsive, and that's the reason why we have all these rights framework that emphasize on the progressive realization of this social for everyone. But while progressively realizing the rights of everyone, that means adopting intersectoral policies, not only health policies, to create the conditions for a better standard of living. There are also those those dear human rights principles like equality and non-discrimination. So equality and non-discrimination shouldn't apply progressively, so it should apply immediately. So to eliminate this differentiation. And so the question is, to what extent we can differentiate based on a legal status? And this entire conversation with stakeholders was around what is this minimum threshold that we cannot take away, these services that we cannot take away because of an illegal status. And this conversation with different stakeholders in Colombia was linking this human right to health, to the well-being of people, to the elimination and the reduction of avoidable, preventable suffering, to the dignity of people. And if we consider all of these interests, actually providing only life-saving treatment shouldn't really be enough, you know? And so the idea was, can we use this primary health framework to identify, let's say, benchmarks and standards to work together in partnership, but also in partnership, encouraging the state to take responsibility of certain, gradually, of certain minimum services for undocumented people. So this was the overall idea. I don't know if that answered your question.
No, thank you. No, that makes perfect sense to me. So thank you. So let's see who has questions and comments. Would you please indicate? Does anybody have a question?
Hi, can I ask one, Jackie?
Yes, please go ahead. Hi, Godars. Yeah.
Hi, thank you, Stefano. This is, I guess, on a much simpler and pragmatic, practical question. We have a number of scholars from Venezuela who are trying to actively connect the Venezuelan doctors back to maybe their own patients or new patients in Colombia. It has some, I guess, legal limitations on whether they can practice really there or not, or whether they can prescribe medication. Have you come across that idea or similar ideas in similar settings? And can that be sort of maybe lessen the burden of the Colombian health system a little bit?
Thank you very much. Thank you very much. Your name is
Gudars.
Gudars. Nice to meet you. So thank you for your question. So during the fieldwork, yes, I met in particular an association of Venezuelan doctors called Manitas Amarilla. So they were mostly operating around Bogota and Cundinamarca region, which is like Bogota is an enclave within this other region. And they were mainly working with NGOs. So basically they were volunteering or contributing to the services of NGOs. So NGOs were funding the service and they were offering their medical and health expertise in a number of programs. There are also so yes, so this is an experience which may relate to your question. They were some of them were these doctors that I met were offering the solution of perhaps being employed for primary care in different areas of the country. The problems that there is at the moment in Colombia is that the care that is offered to Venezuelan and in general to any person that is not registered with the system is an emergency care. So all these other doctors, even if they want to reduce the burden on the health system, actually they are not reducing the burden on the health system, they're reducing the burden of NGOs. You know, so there is so the idea of extending the services, it was put forward also by by Colombian doctors and Colombian health authorities back in the 2016 and afterwards when the crisis started and this mobility phenomenon started to become more and more important in Colombia. I mean, NGOs, but also in particular local authorities, territorial authorities that depend from the central government for a part of their budget for health to extend the services to provide certain primary care services and to demand the state, the national state, to fund this. But they were very easily dismissed. I mean, this request saying, no, let the cooperation do, let international cooperation do that. So and at the moment in Colombia, it's being deliberated in the Congress a reform for health, which is inspired by primary care, preventive care, but there is unfortunately no mention of extending any rights for undocumented people.
Thank you.
Welcome. Thank you.
Any other questions or comments? I can't see anybody's hand up.
I have a question myself for the audience. I assume if I can, what do you think?
Yes, please.
Yeah. So my question basically for you, I mean, I assume that in the room there will be mostly public health specialists. So do you see any, I mean, from what you have heard today, I mean, I know it's not really comprehensive, I mean, about the work that I'm doing, but do you envisage any critical issue of using primary healthcare model as this framework for priority setting and for extending these other minimum services and core rights? So in other words, what do you envisage as, I mean, is this synergy between public health and human rights, I mean, a good synergy, or do you envisage any problems in terms also of, how can I say, I mean, would such a methodology I mean, meaningful? Do you think it makes sense, or do you think there are like particular, I don't know, sectorial priorities that you think this shouldn't really work in practice?
Yeah.
I mean, it's a theoretical speculation, you know?
Yeah. Yeah, it's a good question. Anybody want to comment on that? I mean, from my perspective, Stefano, somebody who knows a little bit about migration, human rights, and not so much about primary healthcare, the obstacle is always this, you know, what are the tools you need to enter into that primary healthcare system? As you say, the default system in so many places is the emergency system. That is kind of like the point at which there is no refusal. But primary healthcare is, you know, covered by insurance. It's covered by this kind of web of eligibility criteria. And so if you're really looking to extend access and extend coverage, or extend, you know, the implementation of the right to health, it's not clear that this tool is actually going to deliver in a context like the one you described. But that would just be my take. But it'd be interesting to hear if people have other views of maybe drawn from other jurisdictions. So I don't know if anybody has a comment or would like to engage. No? No, maybe not. Well, I mean, I think, you know, this is a really, really interesting presentation. And I think what you said in the beginning, Stefano, about, you know, the importance of having this constitutional framework. We know that Colombia is a really unusual country in that sense of having this strong tradition of the constitutional court, a rights-based jurisprudence. You know, it would seem to be, if it can't happen in Colombia, where is it going to happen, kind of thing? You know, what other countries have that possibility? And that's a depressing kind of takeaway, I think, or a spin-off from what you're saying, which is that this, you know, theory-practice gap is quite huge, even in a context where you have a history of litigation and a history of you know, dynamic interventionism from some of the constitutional bodies. So, but anyway, well, listen, good luck with this research. It was very nice to hear from you, and thank you for joining us. Thank you so much for this presentation, and take care. Yeah, thank you. Bye.
Thank you.
Thank you.